Chapter 14, Hypersensitivity. Hopefully by now you guys have, well, you had to log into your weekly agenda to get to this point, but you saw there was a video, and the video that was there is a man, Martin Short, getting stung by a bee in the face, and it's from a movie called Pure Luck. And I know a lot of you probably have never seen that movie, which is why I bring it up in this. I've always brought this up teaching immunology because of the hypersensitivity reaction that he goes through. And while it is kind of funny in his situation, it's definitely not funny when it does happen to somebody in real life. And everybody knows somebody who's allergic to bees. But just when I make that reference coming through, you guys will know what I'm talking about because I posted that little video clip in there of when he does get stung by a bee. And I'm really dating myself. That movie doesn't seem very old to me, but I think it was released in the 80s or early 90s. Not sure. All right, so let's talk about this hypersensitivity thing. So general characteristic is an exaggerated immune response to a typically harmless antigen. Everybody has heard of peanut allergies, has heard of gluten sensitivity, all different types of things that can happen. And we take these and we divide them into different categories. We have 4 categories of hypersensitivity: type 1, type 2, type 3, and type 4. You're going to have to be familiar with each of them and know the difference. All right. 2 different types of hypersensitivity that we see. Immediate reactions develop within minutes to hours after antigen exposure. Think of the little kids with a peanut allergy. As soon as they eat it, their throat gets itchy, their tongue starts to swell, etc. The things that have an immediate reaction, or the types of hypersensitivity, is type 1, 2, and 3. Okay? The only one that has a delayed reaction, which happens 24 to 48 hours after exposure, is type 4. All right, so let's look at type 1 first. Type 1 is also known as anaphylactic hypersensitivity. We think of these as allergies. These commonly occur within minutes to exposure to an allergen. The key components to this, first one is IgE. That causes the release of histamine from mast cells. When you have allergies and you take an antihistamine, it calms that response. We also have basophils and eosinophils that can be involved in this as well. The first phase is the sensitization phase. This is where antigen-presenting cells process allergens and present them to the T helper cells. T helper 2 cells induce a production of allergen-specific IgE. The IgE binds to different receptors on mast cells and basophils, which can cause the release of the histamine that you can see kind of down here. Then we have the activation phase. This is where the allergen cross-links adjacent cell-bound IgEs. The mast cells and basophils degranulate and chemical mediators are released to bind to target organs. Allergy symptoms are then produced to make you nice and miserable and itchy and sneezy. So what are some of these common allergens? Well, these are the ones that come up and they bother the daylights out of me in June. Pollen, mold spores, even animal dander. You know, we've seen kids that can't come over because they're allergic to our dog. Insect venom. You should see my kids. They get bit by mosquitoes and they're scratching the daylights out of their, the mosquito bites. Certain foods, those peanut allergies, shellfish and dairy products. Certain drugs such as penicillin and latex allergies. Some of the clinical manifestations that we see with this type 1 hypersensitivity, you can see a nice little rash here. Rhinitis is what we get when we have hay fever, which is what you might get during, in the spring when you get sneezy and itchy. Asthma, you can have difficulty breathing, having food allergies. Urticaria is another term for hives, which we can call the wheel and flare reaction, which is kind of what we're seeing in this picture here on this slide. Eczema falls into this classification sometimes. And then we can have systemic anaphylaxis. Oh, get it all back. A potentially fatal reaction from sensitized mast cells by IgE. Now, some people have minor sensitivities to food. Our little next door neighbor, she is so incredibly allergic to dairy that if she has it, she goes into anaphylactic shock. So I've always had to be careful when she comes over. There's only certain things that she can eat. I always made sure she stayed away from the kitchen because I was certainly not going to be the one who made her go to the emergency room. But that is systemic anaphylaxis, a type 1 reaction. So what is the treatment for type 1 hypersensitivity? Well, for one, we need to avoid those allergens. There's drugs such as antihistamines, bronchodilators, mast cell stabilizers, corticosteroids, and epinephrine. Epinephrine, do you read EpiPen? Okay, that sounds familiar, right? So that would work for that. Monoclonal anti-IgE antibodies can be given, and there's also allergy immunotherapy, where they administer gradually increasing doses of the allergen, so you're not so miserable when you are exposed to it. I don't know how popular these are anymore, but there is a percutaneous or intradermal prick test. I remember my husband had this done a long time ago. They apply different allergens on separate sites of the skin, and you can see, look at this, the spider up here. Look at the big wheel and flare reaction that happened with that one. They take a little needle, and they put some of this on there, and they poke your skin with it. And if you have a reaction, you can see the spider is a big reaction, the moth, the caterpillar, a scorpion, tick. So you can see the things that they would probably be more allergic to over others. They wait 15 to 20 minutes. It's so incredibly itchy for the patient. A positive test is that wheel and flare that you can see on there. Some other examples, they might do this with rye, wheat, pollen. If you don't know what type of allergy you have, they can actually take pollen and poke you with it and see if you get a response underneath that skin. So let's look at type 2 hypersensitivities. These are known as antibody-mediated cytotoxic hypersensitivity. The key components here, IgG and IgM, that are directed against a cell surface antigen. Some of the effects of these antibodies are cell destruction, cell function inhibition, and an increase in cell function depending on the scenario. This is a lot more damaging. So we have activation of the classical pathway of complement with this, which ends up in cell lysis. So not only do we have an allergic reaction going on, it's hemolyzing our cells. That's a total bummer. Then we have opsonization and phagocytosis of the cell, which, of course, is what's going to happen in the case of a cell being destroyed. Different things that can cause this. Transfusion reactions, if somebody gets the wrong type of blood or a blood that's not 100% compatible. Hemolytic disease of the newborn. We'll talk about this on the next slide, so hold off on that. Autoimmune hemolytic anemia. These are things that can be developed for a number of reasons. It could be because of a drug you're taking. It could be a disease or a virus that's causing it. But it's warm reactive antibodies that just decide to hemolyze your blood. They attach and the complement comes in and it destroys those red cells. We can also have cold agglutinins, which are very similar. And paroxysmal cold hemoglobinuria is another scenario where we might see something like that with an anti-RBC antibody, especially after having viral infections. Goodpasture syndrome, one that can kind of affect the lungs, and Hashimoto's disease is another one where the body actually attacks the thyroid. Let's go back and look at the hemolytic disease of the newborn. While you're not going to have, a lot of test questions on this, you certainly will when you're in the blood bank class, but you do have to be familiar with what it is, so be able to recognize it. So this is caused by the development of antibodies by a pregnant woman to a red blood cell group antigen, usually anti-D. There's more than that, not just D, on the RBCs of the fetus. So what happens? Let's say you have your first baby and you get in a car accident. It's probably the best example I can think of. And you end up having an exchange, even if it's a small exchange, of blood between the mom and the fetus. Somehow, if the baby's blood ends up crossing the placenta into the mom's blood, the mom will make an antibody against baby's blood. Specifically, if the mom is Rh negative, let's say A negative, and the baby is Rh positive or like A positive. So those positive cells end up in the mom. The mom cell's like, no way. They start making antibodies against those Rh positive cells, which we call an anti-D. So things go on, usually ends up okay. Mom delivers, things are fine. Mom gets pregnant again with a second pregnancy. Well, now mom created those antibodies. And when that baby is in utero, if that baby is Rh positive, those antibodies are going to cross back across the placenta and attack that baby. So they were made from sensitization from the first pregnancy, but they're attacking the baby in the second pregnancy. This can cause some serious issues with the fetus and put the fetus in fetal distress. So what they can do, and what they do with all moms who seek prenatal care, if you are an Rh negative mom, they will give you a shot called RhoGAM to make sure this process doesn't happen. In the olden days, before they had this, it used to end up a lot of times in fetal demise. So because we have this in place, that usually doesn't happen anymore. So one of the tests that we do to see if that has occurred, okay, so let's say a baby is born and the baby does have a little fetal distress, we can look and see if those mom's antibodies are attached to those baby's cells. We do something called a direct antiglobulin test. We are checking to see if antibodies have directly attached themselves to the baby's cells, and that's a test that we can do. We can also do an indirect antiglobulin test to see if there is antibodies in the mom's plasma that could potentially affect the baby. All right, the next one is type 3 hypersensitivity. This is a complex mediated hypersensitivity, so a lot going on here. We have key components of IgG and IgM that are directly against a soluble antigen. Small antigen antibody complexes precipitate out and deposit themselves in the tissues. As you can see in this picture here, it's kind of messy. Complement binds, vasodilation and permeability increase, and macrophages and neutrophils migrate to the affected areas and release their lysosomal enzymes, resulting in tissue damage. And there's a few different areas of the body where we see this happen quite often. The first thing we'll discuss is the Arthus reaction. This is a skin reaction caused by type 3 hypersensitivity. There's deposition of immune complexes in the blood vessels, and we see local inflammation characterized by redness and edema. This can peak at about 3 to 6 hours or so. We sometimes see this happen after booster injections with tetanus, diphtheria, or measles vaccines. So it kind of deposits itself in the vessels of the skin. Next, serum sickness falls into this. This is caused by passive immunization of humans with animal serum, so we produce antibodies against the foreign animal proteins. This can cause immune complexes to form and deposit in the tissues as well. What we see from this is headache, fever, nausea, joint pain, rashes, and lymphadenopathy. This usually appears like 7 to 21 days after injection. For example, horse antivenoms are used today to treat victims of snake bites. So we can get serum sickness from that in some cases. All right, other conditions associated. Well, some autoimmune diseases, lupus and rheumatoid arthritis, fall into type 3 hypersensitivity. The reactions to bee stings fall into this category as well. Penicillin drug reactions and sequelae to infections, such as post-streptococcal glomerulonephritis. What happens with that is those immune complexes get stuck in the kidney, and it creates bleeding in the kidney, actually. So how do we test for this? We do anti-nuclear antibody testing to see if there's antibodies attached to cells. We do fluorescent staining of tissues to look for deposited immune complexes. We can test for rheumatoid factor, which would be if somebody had rheumatoid arthritis. And we can test complement levels. They can be decreased in the serum during periods of high disease activity. So if those are low, we could have something going on. All right, last but not least, type 4 hypersensitivity. So this is a cell-mediated hypersensitivity. In this case, T1 helper cells and macrophages are involved. The antigen-presenting cells present antigen to naive T helper cells and help them differentiate into T1 helper cells. Those T1 cells release cytokines that attract and activate macrophages. Macrophages induce the inflammation at the site, and cytotoxic T lymphocytes are recruited to destroy target cells. Hypersensitivity peaks at 48 to 72 hours, which is why we call it delayed reaction. So some examples of things you can have: infections with pathogens such as tuberculosis, Mycobacterium leprae, Pneumocystis carinii, Leishmania species, herpes, things like that. Another one is contact dermatitis. I can't wear like cheap jewelry. I'll show you a picture here in a minute. Hypersensitivity pneumonitis, so allergic diseases of the lungs. We can get this from bacterial or fungal spores. Some examples: farmer's lung disease, bird breeders' lung disease, humidifier lung disease. So if you get some bacteria in your lungs, it can cause a hypersensitivity. This is probably the most common. So it's low molecular weight compounds that contact the skin and act as haptens to sensitive T1 helper cells. So if I wear cheap jewelry, this is what my skin's going to look like. if I were to wear earrings that had like nickel in them or something that's just cheap metal, I end up having a reaction like this. Poison ivy falls in this category, poison oak, nickel, materials in cosmetics, certain hair dyes, and latex. We see these skin eruptions with swelling and papules. It's kind of gross and gets crusty. So we can test for this by doing a patch test. Where an antigen is applied to the skin, and we test for contact dermatitis. It would be positive if there was little blisters. Another one, which you will be very familiar with, is the Mantoux method. This is where an antigen is injected intradermally. The most common one is tuberculosis exposure. We call it a PPD, or a T cell function test. So I'll show you a picture. Here we go. So you can see they inject a little bit of like tuberculin antigen underneath the skin, and you can see the bleb forming. A couple days later, they look and see if there is a hardened raised area, which is an area of induration, and the area of that is measured. And if it's positive, it could mean that you've been exposed to tuberculosis. Okay. Other ones they do that for, sometimes they do it for like Candida, if someone's got some other issues going on. So here's some helpful hints for you. Type 1 is a bunch of A's. Allergic, anaphylaxis, atopy is another word for allergy. Type 2, antibody. 3, immune complex. And 4 is delayed. Okay, so if you want to help find a way to, if you don't remember anything else, this slide will help get you through quite a bit. There are some other pictures here if you want to see what's going on. So type 1 has the degranulation of the histamine from the mast cells. Type 2, we've got the attachment to the red cells that can cause hemolysis in the case of hemolytic disease of the newborn, things like that. Type 3, we can see the immune complexes depositing themselves. And type 4, we've got that T1 helper cell issue going on. All right, that concludes hypersensitivity, and I hope you guys have a great day.